So I'm going to give you some background on what is patient-level prediction and what it's not, and how we want to solve that problem using our framework. Jenna will have a presentation after mine, after the break, where we will really go into depth in the functions and functionality in the package. I will give more high-level overview. So we will learn what a prediction model is, patient-level prediction modeling process, and gain some insights of a proof of concept study that we have done earlier on in depression patients. So clinicians are confronted with prediction questions almost on a daily basis. You have a patient in front of you, and he has read something in the news that if you have a major depression, you may have a higher chance of experiencing a stroke in the future. And they want to know, what is my personal risk of getting a stroke in the future? So the doctor has a couple of options for that patient. One could be just to deny the ability to predict at individual patient level, and that can be a very good solution if that is the case. However, most of the time, what he does is he quotes an overall average to all patients. So we know that the incidence of stroke in patients with major depression is that high, and that would be the advice to the patient. But that's, of course, not tuned at all to that specific patient in front of him who may have a certain history of events. He could use knowledge in his own practice of patients that look like that patient who may have the same history of diseases, and he could extrapolate that knowledge to the new patient. But that's, of course, very suboptimal. And it's very hard to do, because how do you compare patients in your practice is not an easy question. So what the doctor would like to have is some sort of support, a kind of personalized prediction using some advanced clinical model. And that's what we are building here in this tutorial. We've seen the problem definition. The T and the O and the TAR will come back many times during this tutorial. These specifications we just done, and these are the different questions that we can answer using the framework. I want to start with explaining a little bit what the differences are between explanatory models and prediction models. I think it's a very important thing to understand what we are actually doing here and what we are not doing. Especially starting with the term model. So the interpretation of the word model depends on your background. People who come from statistics, they see model as describing data. It's about probability distribution. That's the model. People from epidemiology are trained to think in models as causal models, right? Data scientists like me, we see models in the context of predicting future events using the available data that we have in our data set. There is really difference in how you use the model, whether you use it to explain, to look at causal things, or use it for prediction. And we've sent you these nice papers from Sumeli, which I think are very nice and give a very nice overview of the differences. And I also sent you a link of a video where she explains those differences. If you are really interested in that, I would really recommend to look at that video. I'm going to take some of the elements out of her paper here, which I think are very important in our context. So some definitions. So what's an explanatory model? Explanatory model is like a theory-based statistical model for testing causal hypotheses. And the explanatory power is here really the strength of the relationship between the causal factors and the outcome. Prediction model is a model to predict new observations that will happen in the future. And the power is the ability to predict that accurately in the future. So we need to have measures to assess how well we are able to predict in the next year. And of course, you can empirically evaluate the predictive power of an explanatory model. That's fine. But the other way around doesn't work. So you cannot assess the explanatory power in all its level of detail that you would like in a predictive model, because we do not assess the causal inference or the causal effects. It also means that the best explanatory model for looking at causal effects may not be the best one to predict predict outcomes. using the available data. And that's important to realize. We use data like data-driven approaches where we use all the available data to predict as good as we can in the future, but it doesn't mean that the predictors that we find tell us something about causal effects. That means we actually don't have to understand all the causal relationship to be able to predict well, and you will see that in some of the examples that I will show. So there are different ways of building these type of models depending on whether you want to do explanatory models or predictive models. I'm going to focus on predictive models here. The analysis goal is here really to assess new observation in the future. We use all the available data that we have in our data set, and we want to minimize the bias and the variance in our model to get a best prediction model, but we want to avoid overfitting of the data, of the training. And I'll give you some examples later of that as well. The predictive models can only be built on data that we have available at that moment. So we will not put in data that we think that may be causal factors based on literature. It will not have no effect on our prediction model. We really want to use the available data for building that. And the predictive power is the accuracy of the out-of-sample prediction, meaning we have to divide the data set in a training set and a test set, and sometimes a validation set. I'll show that as well. But you need to have other data to assess how well you're able to predict your outcome. So one of the things that we try to educate when we're doing these type of tutorials is that we avoid the term risk factor in this type of questions, because many people have a causal relationship when they think about causal factors when we talk about risk factors. We like to talk about predictors here to make very clear that what we are looking at is the association between a variable and the outcome and not a causal relationship. If you want to look at causal factors, which is of course also very interesting, you have to look at more like the other tutorial, the risk effect estimation, where you try to balance two types of patients and correct for all their covariates using the propensity score approaches, for example, and then look at the individual effect of adding one variable. This is not done here. And one very good example is, and I'm often confronted with that, is if we build a model, a prediction model, the first thing the clinician says, can I have a look at the risk factors in the model, because I like to explain why they are there and I like to understand it. It's a very logical question because that epidemiologist is coming from with his causal background. However, we need to realize that if you have a prediction model, and this will be the only, I think the only formula we have in the slides. You don't have anyone? Anyone? Yeah. one formula, a simple one, a regression model. It's important to understand what these betas actually mean. So if the beta is 0, meaning the variable is not in the model, it doesn't tell us at all whether there is no, the conclusion should not be that there is no association, because there can be other variables in the model that are very highly correlated to that one, that are actually a proxy for it. We also know nothing about causation here. If the beta is not 0, we do know that there's association between that variable and the outcome. So it's important, it has some predictive value in our prediction model. The sign of the beta is important, but you can see in some of the prediction models, if you remove one of the variables, the sign of some of the betas may change. So it's hard to interpret the beta that's positive to be positively associated in general. It is positively associated under the assumption of all the other variables in the model. You may wonder why is prediction modeling still a valuable thing? Often, and the example that I gave in the beginning of the patient with at the doctor, it's important to understand what's going to happen with me at a certain moment in time, and it can in some situations be even more important than why. I just want to know what is my risk of getting a stroke in the next year. Another thing, and that's actually, the good example was yesterday when we did that big study, that knowing that something is difficult to predict is valuable on its own. So we got a low AUC yesterday, But it's still very valuable to have that information. Skip that. Any questions about this first session? We are a little bit out of time, but yeah, go ahead.
I just feel a little weird, like, do you have any citation, like why most people would agree the prediction is more important than the explanation? Because in which scenarios would people just care, I can optimize the prediction, but without being able to explain it? In which situation people would accept that?
So actually, Ewout, you gave an example, right? Where you say that the chance of having a certain outcome can help you assess which type of drug you should take, for example. So like the thing that Ross did in his presentation yesterday, where the guidelines say that if you are at a high risk of heart failure, you should take this drug or that drug. In that situation, the prediction model could be useful.
Yeah. So I think in general, I like your explanation, Peter, that prediction models, in the classical sense, that also if you see that in the major journals, they have these two purposes. One is just very pragmatic, you give a risk estimate, and the other hand, you can understand why this arises. So if age is one of the components of the risk equation, that people can understand, yeah, older people, they're frail in some sense. There's some biology behind it, people can understand. So I think this two issues, they go together often. But here, I think, especially if you look now in the OHDSI context, it's really going to high dimensional and having 60 predictors. And yeah, it's really the primary thing is just to provide an accurate risk estimate. And I think for pragmatic purposes, like selection of patients for more invasive therapies, more burdensome therapies, that's all very useful. So the main thing is to validate these models across different settings then to see whether it really works. Not whether to inspect the model per se. This is just a black box thinking.
Okay. I'm going to continue because of time. There's really a growing interest in prediction models. And you see here all the papers that have something about prediction in their titles. And what I did on the right is we looked at all the diseases that were in the titles of these papers. And we made a Wordle, so this shows the frequency of those words in that literature. And you see a large diversity of diseases that have been studied and prediction models have been developed for. Heart failure is very often studied in literature. Also, this slide gives you an overview of the number of models that are being developed in certain disease areas. So cardiovascular disease, 800 models, a large amount of models. And the question is how many of these models actually end up in clinical practice. One example is the stroke model that we'll be talking about more in the presentation from Jenna. The CHATS-2 score, that's about predicting stroke in patients with atrial fibrillation. It's a very simple score. It's like weighting a couple of variables in the model to give you a probability of the outcome. So the target cohort is here, patient with newly diagnosed atrial fibrillation. Outcome is stroke, 1,000 days. And they use the logistic regression model with 5 pre-selected covariates. A nice paper that I also sent you as homework, and you may have read it. This paper gives a nice overview of some of the prediction work that's been done and the challenges and opportunities that we have to improve on that. One of the things that was mentioned there, and I fully agree with that, is inadequate validation of these models. We need to have more extensive external validation, what we actually showed yesterday in the presentation of Jenna and the work that we've done. It's often done on small sets of features, and it would be interesting to understand how much better these models could be if we have more data and we use a more data-driven approach that we've been advocating for in OHDSI. The third point is also very important. There are a lot of papers out there that report that they've built a prediction model, they have an AUC, but they don't share their models. So you're actually not able to replicate the study. You're not able to understand fully how they built the study. It's very unclear how they defined their outcomes, etc. And that's we get back to that after lunch a little bit when we look at the CHATS-2 paper. But that's a big problem. And I think in OHDSI really improve in that area because we standardized the whole pipeline and we built nice tools and also nice result sets that are all standardized. Transportability assessment, impact of clinical decision making is a very interesting research area still. How do we assess what the effect is of the model in clinical practice? And there are not many studies there. That means that few of these prediction models really end up in the clinical practice, and I think that's something we need to improve on. So we try to help this field by building the tools, and I will go through how we think we should create the evidence, how we should evaluate the evidence, and how we should disseminate the evidence using our patient-level prediction framework. So we build a couple of steps, and that's what we actually did yesterday. We started with a problem, a definition, and you gave a problem here, or selected a problem. It's important that this is very clearly specified, and we need to have a protocol in place that specifies all the definitions of the cohorts and how we want to, what type of model we want to build, and what covariates we want to use for that. Everybody should be able to reproduce your study on their own data, and that's possible using the approach that we implemented. Data extraction, we talked about that, and Patrick talked a little bit more in extent already because of the question of about. Target cohort and outcome cohort, we defined two cohorts. The nice thing about that is also that we can reuse these cohorts, so an outcome like stroke that we defined for chats could easily be used as a target cohort for another prediction problem. So we are able to create like a library of outcome cohorts, or cohorts I should say, that we could use either as a T or an O in future studies. Data extraction. So we can build the cohorts in Atlas, and then Jenna will show how to do that. But then we need to extract the data. We need to extract features from all those patients that are in the target cohort to use them, that data for doing the prediction. And we built a package called feature extraction in R that can help you do that. You can specify which variables you want, in what time windows, and you can extract the data and then use it in the next step, which will be the training. Training and internal validation is, of course, crucial. We need to have data to build our model on, but also to internally validate that model. So we normally split the data in the train set and then test set. And that can be done in the current framework in two ways. So either person split, so a person is randomly assigned to the train set and randomly assigned to the test set. But what we can also do is a time split. So there you say patients before a certain moment in time belong to the train set, and patients after that moment in time belong to the test set. I think this kind of temporal validation is a very interesting approach because things may change over time in the system, and therefore this may be a good way to assess that effect. So model training. Here we have to answer a couple of questions. So which model are we actually going to train? We have a whole set of algorithms out there, and how do we evaluate the model? We've implemented in the framework many types of algorithms. Regularized regression, random forest, which is a tree-based approach, where a subset of the patients are selected and a subset of the variables are selected, and within that subset we build a tree, and multiple of these trees are built in parallel, so it's a kind of ensemble of trees. That's why they call it a forest. And there's a majority vote across the trees, and that will be the final prediction. Gradient boosting is also tree-based methods, but there you re-weight all the time. So you build a tree, and those patients that were wrongly classified are getting a higher weight in the next tree. So other algorithms that are in the model, in the framework, are k-nearest neighbors, naive Bayes, a lot of machine learning algorithms. We will not go in detail in all these algorithms. That's a full other course. But we'll give you some examples later and how to run them in the framework. Also, deep learning we've been working on recently and added that to the package. So if people are interested in that, we can have a private chat about that later as well. So selection of a model, it's important to understand the no free lunch theory. And what that actually say is that there is not one model that will work for all problems. We need to just assess multiple models in our problem space and then pick the one that works best. We cannot say that lasso will work for all problems that are out there. That may completely depend on the type of problem. And what we have implemented in the framework is that you can actually run multiple of these models and then select them on your training set. So one strategy is, and this is one thing that we always do, is you order them in the way you think that they may be good. And our experience is actually that lasso is always a very good thing to start with. It gets a pretty good performance overall, but there are certain examples that we also saw where we saw that random forest or gradient boosting have a good performance. So we start with one and we look at the performance of the model. If it's adequately for our context, we could just use that one, but we could also change the parameters in the model, and Jenna will go a little bit more in depth. So what are those parameters and how can you actually how do you make sure that you get the right parameters using the internal or the validation set in the training set? Yeah?
How do you access the performance is adequate?
That's a good question. It depends a little bit on what you want to do. So I will get to that in the ROC curve, and maybe we can talk about that then. I would like to postpone that a little bit. Change the model parameters, hyperparameter training. We could also say we want to include other covariates. So we have initially decided to use only procedures and drugs. We should also add maybe measurements in there. So that could also be something that you change. Another thing would be take another database. So if you just don't have the data to do a good prediction, you could try it on another database. In the end, if you are not able to have a good prediction, you could, of course, then that's the end. You don't have any other options there. But we do recommend that you publish that as well. So don't keep it for yourself. These whole proposal that we here have is really still research, and we need to assess on large scale what are the best approaches for selecting the algorithms to do our modeling. Evidence evaluation. So what makes a good model? We should look at two things. So discrimination, that means how well are those with and without the outcome differentiated? So do we predict higher probability for those with the event compared to those without the event? And calibration, that is the estimated probability, so the probability of getting the disease, is that in line with what we really observe in our data set? So how to assess discrimination? So let's take a very simple example where we say our model is BMI above a certain threshold, and then that means we get some outcome. Suppose we have two classes here that have their own probability distribution. So people who get the outcome are 0, and those do not get the outcomes are 0, and those who get the outcomes are one red here in this image. So the choice of that X here, that level, determines how many of the people will get according to our prediction model, will get the outcome and who will not get the outcome. Let me move this. So we can create like a simple table where we have the people that are predicted to have the outcome here and the people that are observed to have the outcome on the y-axis. We can simply see that the true positives are the one on the right of the line because they actually got the outcome, and because we say people above this level are going to get the outcome, we have made the correct prediction. So these are the true positives. The true negatives are the ones that are on the left that indeed did not get the outcome. The others are the false negatives and the false positives. So those we are incorrectly classifying. because they should actually be on the other side. So these people here, because we take this limit, are seen as are predicted as having not the outcome, but they actually do have the outcome. So we can calculate two different things here, the true positive rate and the false positive rate, which are actually just, well, shown here, the true positives divided by the true positives plus the false negatives. You can plot those two things in a diagram, which you see here, false positive rate on the x-axis and the true positive rate on the y-axis. By changing your threshold, you will actually move over the ROC curve. And I'd like to show that in a small animation. So you will see that if I change that threshold, I'm actually moving over the ROC curve. So that gives me a different choice of my sensitivity and specificity across the curve. You also see that there's an area under that curve, and the higher the area under the curve, the higher the discrimination. So if those two distributions now move closer to each other, you will see that the area under the curve is going down. It's much more difficult to discriminate those with and without the outcome. If they completely overlap, so if they all have the same distribution, the people with and the without, you are not able to use BMI for your prediction problem, and you will actually be on the diagonal. So like 50% AUC. And it's important to keep this in mind. We often talk about these receiver-operator characteristics curves, but this is the thing that's behind it. It's those two distributions that the overlap actually determines how well you're able to discriminate, so how big the area on the AUC is. And the threshold determines where you are on the curve, and that may depend on your context. Calibration is another very important thing to assess, and you see many papers that do not assess calibration, and we think that should be there for every prediction problem. That's the agreement between the observed and predicted risk. And what we want is a model that has good calibration across the range of predictions. So not just on average, but for each of the individual levels of prediction probability, it needs to match with the really observed frequency. So a model is well calibrated if for every 100 individuals, giving a risk of whatever percentage, indeed that amount of people do get the event. So for example, if we predict 12% of risk for that an atrial fibrillation patient will have a stroke within a year, the observed proportion of people should also be 12 out of 100. And the calibration curve is actually visualizing that. So the average predictive probability and the observed fraction of people with the outcome. And if we do a very good job, everything will be on the diagonal, but that's often not the case. And if we are lower, so we're actually overestimating and underestimating if we are above that curve. Yeah?
For calibration, would you consider interaction terms or fitting separate prediction models for different subpopulations?
Yeah, so yeah, you could do that. Yeah, you could do it for different models and then assess that with the calibration curve. Yeah, it's not done in one calibration curve, so you have to build multiple models and then assess that effect. Yeah. External validation is also something that we really want to push for, and like we showed yesterday with Jenna's work, we need to assess how well our models work on other data sets. And too often we see publications where there's done internal validation, we get a performance, but we actually don't know at all how well that model will work on our data. So the more we can do that, the better. And also Ross's presentation yesterday gave a nice example of doing that against other databases. So have one database and then train it on one and assess it on all the others and then rotate that. I think it's a very nice approach. And of course, assess then the AUC and the calibration across that exercise.
Peter?
Yeah.
How do you choose whether to use some data set for external validation so it will not give any additional benefits for your model builder? So either use this data set for training the model. So the more data you have, probably the better model you have.
Yeah.
But that model could be overfitted for this data. That's why you need external validation. How do you find out this balance between those two things?
Well, I don't think there's a clear answer to that question. And
what's the approach you use? I get that.
Yeah,
It's
yeah,
a balance, but how do you pick it?
yeah, so we take the approach that I just talked about. So we take all the data that we have, and we do all the iterations of that to get more insight in that. But there are data sets that will match better than others. So if I have data in a hospital, assessing that external validation in a hospital data set will probably be better than using it in another data set. But if my question is to build a model for data sets that should be used in a hospital, I should focus on those data sets.
So Peter, if I may add, I think it's a great point. As you also recognize, it's a really important question on, so how long do you want to continue preventing, say, overfitting? So you want sufficient size versus you want to start exploring the transportability. And I think it's an open research question, and there are some, say, default approaches Peter explained.
Yeah. Evidence dissemination, critical, and we'll dive into that a little bit more after lunch with the tripod statement. How should we report our models? There are some minimal requirements, but we like to push that further. So what we want to build is a website that contains the models that we created on our OMOP CDMs, so people can download that and run them on their own data. So our general, I think, our OHDSI vision is that we like to move away a little bit from static journal papers where we do a study and we report it. I like to go to a situation where we have dynamic results. That means that we publish a paper, we put the data online, but you're welcome to run that study also on your own data and then add your results back to the website so that body of knowledge is growing over time. And I think we have a very unique opportunity to do that in OHDSI, and we should share all those results with the community. I think that would really make a big change in how we do predictive modeling in general, but also all the other methods development that we do in OHDSI. So we are moving to that. We hope to progress more on that in the upcoming year, where we can make that happen. I'm going to go. We already had a. Yeah, you have one question. Yeah.
Question about the calibration. So in the example of, say, 12%, we're trying to predict that, say, 12% of the patients are likely to get outcome X. And then you can compare the model 12% versus the population 12%. So you're trying to predict whether a patient has depression or some clinical event. What metric do you recommend using to evaluate the prediction of the model? Because AUC gives you a general sense, but you're generally using a particular classifier. And then you need to look at the positive predictive value and the specificity, or the F1. What's your general kind of sense of how to report that the strength of the classifier to predict a specific event, depression?
Yeah, so we implemented actually all the measures that you mentioned as well, so we can assess that. I don't think there's a general answer to that question. It depends on the context that you have. For example, which point on the RC curve you will pick. Completely depends on the context. We look at all these things together and then place it in the context of the question and then make a decision whether the model is right or not. Do you have anything to add to that, Ewout?
No, this point on calibration, that's what we often see in transporting models, that the average prediction is off. That's really the most common thing. And that also impacts on the measures that you mentioned, like true positive fractions and positive predictive value. These are just specific points at the ROC curve. So there are proposals, and it's still in progress, I would say, summary measures for a given cut point, given threshold, which also have a link with decision analysis, like a measure like net benefit has been proposed and is becoming more popular. So if you want to go beyond ROC curves, I am in disagreement with my co-author Michael Pensina, who had this net reclassification index proposed, but I'm in favor with Andrew Vickers, who proposed this net benefit idea, that you have true positives minus a weight times false positives, and this weight is dependent on the context. So this is context is a specific issue.
I like to move on. We can discuss a little bit in break because we are a little bit out of time. I'll do that. I'd like to go to the last part, depression example. This is a study that we presented at the OHDSI Symposium. I just wanted to use it as an example on what we can actually do with the package. So in this question, the question is, among patients in 4 different databases, we want to develop a prediction model for people that had a first pharmaceutically treated depression, and they experienced 22 different outcomes. So we built 22 different prediction models in this problem space. The time at risk is 1 year, and we want to predict using all demographic data, all conditions, and all drug areas prior to that moment in time. We define cohorts. Patients should have at least 365 days of history, a certain amount of follow-up time, and no occurrence of the event prior to the index date. We run that on 4 big claims databases. And here on the right, you see the list of outcomes that we built prediction models for, selected by experts. And we did a train and test set split using the time split approach. We compare different models, so we run gradient boosting, random forest, and regularized regression, and assess the performance of those 3 models within this problem. If you look at stroke, the thing that I mentioned at the beginning, the example of the patient visiting his GP, here you see that in these data sets we had 1,300 people with stroke, quite a large number. What we did is we run, using the framework, all those three algorithms on all the outcomes in all the databases. And the figure that you see here summarizes all those results. So there are panels here. This is the first panel is 1 database, second database, third and fourth database. And the columns are the diseases that we predicted. So there are 22 different columns here, and this is the stroke one. So we see here the area on the receiver operating curve, so the discrimination of the models. And yeah, green is above, well, starting at 80% going up. And yeah, bad models like 50%, so that's the example where those 2 distributions were completely separated, overlapped. You could not get any prediction. It's like 50% on the AUC. You see here that we are able to predict that well, and that there's not a lot of difference between these different algorithms. The nice thing is that because of the framework, we can scale this easily up very easily, and we can create this type of figures where you have an overview of the discrimination of all those three different algorithms across the outcomes, across the different data sets. And there are a lot of interesting things to see in these plots. For example, MDCR, we are not able to predict very well here. Older population can be one of the reasons. We also see that some of the outcomes we are able to predict very well across all the data sets, and some we cannot. And I think that's also interesting information because that could help us prioritize maybe which of the outcomes we like to go for. On average, there's quite a lot of these outcomes that we are able to predict at the AUC higher than 75%, which is, I think, pretty good. Best one was acute myocardial infarction that got an 86 AUC. Which is, I think, very, very high. Other things that we want to assess, and that's coming back to the choice of that algorithm, how well do the different models discriminate? And on average, I think they are all quite comparable. We have about the same colors in this figure. But there are examples like here where the gradient boosting is performing better than the lasso. And one of the research areas that we could go into is to understand better why this model works good for this problem and not good for the other, and not so good for the other one. So in general, what we achieved so far is that we built the framework, have possibilities to do internal validation. We use all the data. We have ways to disseminate the models and do the transportability assessment. I think the last point is really something that we need to invest more time into the impact on clinical decision making if we put those models into practice. That's something that we really have to push for. I don't like the idea of us just adding more prediction models to literature without having any impact on the data, on the patients. There are a lot of books out there to go into, to read if you want to. Now Ewout's in the room. I can, of course, not. I really recommend your book.
Oh, yeah. Just highlight one.
Highlight, it's remove the other three. This one.
So let me be very honest. The regression text by Frank Harrell is really a classic, and that inspired me for a more practical version. So the most left is really more thorough, has more formulas if you go through it, more computer code, more R scripts. The second multivariable is by my friend Patrick Worstin and Billy Zaubright. They focus on modeling non-linear regressions, and well, that is kind of thing that OHDSI takes up naturally, I think, in the model approach, or you dichotomize. We can discuss that. And the final one, Elements of Statistical Learning by Hasty Tips Rai, that is really very solid again.
Yeah. This is very depth and goes to very depth.
Many formulas.
Depends on how many formulas you want.
So I think the Elements of Statistical Learning is also basic for more machine learning, more fundamental concepts, but quite theoretical, or quite many formulas. Well, mine is and the two middle ones are more applied.
Right. Good, we're going to have a break for 15 minutes and then we get back.